A lot can go wrong in a preemie. And so generally when a child is delivered premature age, especially less than 30 weeks, they're probably going to end up in the neonatal ICU. For you, I want you to be aware of the 4 major diagnoses. Trying to understand fluids, hemodynamics, and ventilation perfusion stuff that's basically ICU level material is probably beyond your scope. But you want to know the diseases, how to screen for them and make the diagnosis, and what you can expect if a child develops one. Let's start off first with the lungs, and that is bronchopulmonary dysplasia. And bronchopulmonary dysplasia is effectively a long-term consequence of respiratory distress syndrome. The pathology of respiratory distress syndrome, and therefore bronchopulmonary dysplasia, is going to be decreased surfactant. And what happens is you have derecruitment of alveoli. There's changing the pathogenesis, and to try to explain it really isn't worth the effort. But basically what happens is that the lungs are underdeveloped. They don't have the lubrication to easily expand the alveoli, and therefore alveoli don't work so well. Therefore you can't get oxygen into the blood. This goes on long enough and you get scarring. What you're going to see is a premature infant who has increased oxygen demands. You will increase the FiO2, and as we'll learn, that can be dangerous as it predisposes to some other diseases developing oxygen toxicity. And you'll want to perform a lung protective strategy. That is, we've been changing the way bronchopulmonary dysplasia is defined, and what you're looking for is someone who has a tough time ventilating because the alveoli are stuck, and have a tough time oxygenating because the alveoli can't be recruited to exchange oxygen. So as the kid gets increased amounts of FiO2, what you're going to try to do is give a little extra PEEP to keep those alveoli open, but eventually, if you have to provide more pressure, you have an increased chance of developing this chronic fibrosis. The diagnosis is going to be made with an X-ray, and what you're looking for is ground glass opacities. That is, you're seeing the evidence of the pulmonary disease, the scarring. Technically, in order to be bronchopulmonary dysplasia, you're going to need to have increased FiO2 requirements for greater than 28 days. That's how the shift from RDS to BPD occurs. The treatment is going to be surfactant. We know that it's a problem with underdeveloped lungs that don't have that lubricant. Give them the lubricant that's in the child after delivery. The other thing we know that works is to give steroids. Corticosteroids to mom antenatal. That is, in the patient where you're going to have the mom come in, you know she's preemie, she's starting to give birth. You try to stave off delivery a couple of hours or days with abortifactants, and you give the steroids. What you're basically going to end up with is diffuse parenchymal lung disease, pulmonary fibrosis, interstitial lung disease, whatever the case may be, diseased lungs from scarring. This I spent so much time on because these other diseases are sort of predisposed by increased oxygen demands. Retinopathy of prematurity is going to be caused by neoangiogenesis, a process that is worsened by increased FiO2 requirements. The idea is that the developing eye is going to make blood vessels. When delivered prematurely, that process continues but haphazardly. So the angiogenesis is not doing anything useful but making these new blood vessels on top of the eye, which can lead to blindness or retinal detachment. The patient is going to be a preemie, and they're going to have increased FiO2 requirements, and you're going to do an asymptomatic screen. Every baby who's born premature is going to get an eye exam, and you see the blood vessels. And if you see those blood vessels, the treatment is going to be laser ablation. Photoablation gets rid of those bad blood vessels in an attempt to rescue the eye. Even if you do treat it with the laser, what's going to end up happening is early glaucoma. Of the brain, you want to be worried about intraventricular hemorrhage. This is caused by the highly vascular lining of the ventricles. They're also very susceptible to changes in blood pressure. Say, for example, the premature neonate who's battling septic shock on and off of pressors and fluid boluses. That vascular lining involutes around week 34. But if you're born prematurely, you have this highly vascular bed, which is susceptible to changes in blood pressure, which can bleed. The patient is going to be an asymptomatic screen. Every preemie before 30 weeks is going to get a screen, and you're going to image again later. But if they bleed after the imaging, what you should suspect to see is an increased intracranial pressure. Remember, babies have this little pressure gauge called fontanelles. So if you see bulging fontanelles, seizure, or comatose, start thinking about intraventricular hemorrhage if it's in a premature infant. The diagnosis, along with the screen, is going to be made of the cranial Doppler. Remember, they don't have enough space to bleed out in the brain, but what happens is it causes mass effects and increases in intracranial pressure. So you're going to manage the intracranial pressure by trying to decrease it, and that's usually going to be in the way of surgery, right? If it's going to continue to bleed, you're not going to try to turn off the bleeding necessarily with medications. You're going to put in VP shunts and drains. How big the bleed is and how bad the pressure gets is going to determine how bad the sequela is. Thinking about things like mental retardation and seizure disorder. And lastly, it's included last because we talk about it in some of the other sections in pediatrics, is necrotizing enterocolitis. This is effectively dead gut. And this one is a board favorite. The patient's going to be a preemie in the neonatal ICU, probably has one of these other diseases, and then has a bloody bowel movement. What you're going to do is get an x-ray. And this is why it is a board favorite. If the x-ray shows you air in the wall of the intestine, pneumatosis intestinalis, air in the wall of the bowel, pathognomonic necrotizing enterocolitis. If you see that word, it's done. The treatment is going to be with NPO, that is bowel rest. And you have to give IV antibiotics against gram-negative organisms because translocation of the gut flora can occur during this ischemic period. And also the kid is still growing, so you want to give him the nutritional support that he'll need by using TPN. And surgery is a potential outcome if a lot of the gut dies, which can lead to short gut syndrome. So basically every preemie who's really sick in the neonatal ICU is going to be checked for these things. If you see the bloody bowel movement, get the x-ray looking for the air in the wall of the bowel, pneumatosis intestinalis, necrotizing enterocolitis. Preemie is going to get screened with the cranial Doppler and re-imaged later on. Don't forget, look for the signs and symptoms of intracranial pressure being increased, and you're going to use drains and shunts. If instead you have a preemie and they talk about the eye, look for retinopathy of prematurity. It's going to be something you do as a routine screen, and you laser blade it away. And the lungs are the big deal, right? So if they have respiratory distress syndrome from underdeveloped lungs, you want to give them surfactant to help lubricate and open up those alveoli. You can give antenatal steroids to mom when you know a premature infant's coming out. And then as you treat the oxygen needs, keep them at a minimum of what you can. Keep the FiO2 down to a minimum level and use lung protective strategies to try to keep the pressures down as they get through this initial period. If you have pulmonary problems for too long, you get bronchopulmonary dysplasia, which is effectively the same thing as diffuse parenchymal lung disease in the adult. See the correlate, respiratory distress syndrome is ARDS, BPD is DPLD. Those are the diseases of the premature infant.